You've been feeling short of breath, you've been experiencing dizziness, and you've been feeling like your heart's been beaten out of your chest. In today's podcast, we're going to be discussing a possible cause for these symptoms. Hi everyone, and welcome back to the Longevity Podcast. I'm Jess.
And I'm Lee.
And in today's podcast, we're going to be discussing atrial fibrillation. So we actually had a question from one of our listeners when we were asking if there was any topics that people would like us to discuss, and it came through that this particular listener had a family history of heart disease and they wanted us to discuss possible heart conditions. So that's why we've chosen to discuss atrial fibrillation today. Now obviously this is one of many different heart conditions, but we will be discussing other ones in further podcasts, but yeah, today will be all about AF.
Yeah, I mean, one of the main reasons is that over the last 10 years, this has increased by 50% in terms of being diagnosed and being found at a general review. And like you said, we're going to go on to general heart conditions such as heart attack in future podcasts and build up with blood pressure, cholesterol. So we thought it was a good opportunity to discuss a common heart condition, but not many people will know about.
That's true. And like I said at the beginning of the podcast, this particular condition can present with quite kind of common symptoms that you may not really associate with your heart. I think it's just important for us again to bring awareness to the condition. Like you say, it's increasing in the amount of people who are being diagnosed with it, and as we will discuss, the consequences of it lying untreated and being undetected can be catastrophic really. So yeah. Probably the best place to start then would be to discuss what is it and what is the actual condition. Atrial fibrillation is a condition of your heart, so it affects the electrical signals that pass through your heart. So your heart has got 4 chambers, so the top 2 chambers are called the atria, and then the bottom 2 are called your ventricles. So your atria are what receives blood. So one side receives it from your lungs, where after the blood's been oxygenated, and the other side receives it from your body once your cells have used that blood to carry out various processes. Now once the blood is received into the top 2 chambers, the atria, your heart will then contract in a regular manner to then take that kind of like squeeze the blood out of the top into the bottom ventricles. Then the ventricles will pump blood to either the lungs to then go and receive more oxygen to take it back to the heart, or it will then go out of the ventricles into the aorta to go to the rest of the body to give your body the oxygen that it needs. So with atrial fibrillation, the electrical signals kind of get a bit disturbed and they go awry, so they're not able to beat in unison. So that's why you get an irregular heartbeat. It's kind of like the top 2 chambers of your heart are just kind of going a bit crazy. So what that means in terms of the blood is that it can't be pumped out or squeezed out efficiently. So in patients with atrial fibrillation, the consequences come when this blood kind of sticks around for a little bit longer than it should do. It then can lead to the blood clotting, and then if this clot leaves your heart, it can then travel up to your brain and cause a stroke. Obviously, like we said, could be catastrophic. There's also something called atrial flutter, which is similar to atrial fibrillation in the way that it will cause fluttering of the atria, but it's more regular rather than it being like all over the place, which is atrial fibrillation.
That's the biggest thing. Yeah, atrial fibrillation, the electrical impulse can start from anywhere within the atria. So in a normal heartbeat, it's regulated by the sinoatrial node, which is in the top left. That beats across the whole of the muscle and allows it to contract in one big rhythmic cycle. And then it comes to another node which then allows it to pass along the fibers, etc., to your ventricles. In atrial flutter, it is more coordinated, but it's still not rhythmic in terms of its contraction. But the biggest thing, like you said, is when the blood is not moving as it should do, it sits at pools, then it can make these things called thrombi, which are clots, and then that can pass to your brain, which then can lead to a stroke. In terms of atrial fibrillation, it's not as detrimental as ventricular fibrillation, so that can be life-threatening. Whereas AF, the blood still passively goes through 20 to 30%. Yeah,
I think as well, because it's your heart, the signals actually, even though your heart at the top 2 chambers, your atria, can be beating at like 140 beats a minute, which is a very high. Obviously anything above 100, just for our listeners, is classed as like tachycardia, which means a fast heart rate.
Which is something that we'll discuss later, that they actually recommend less than 110 beats per minute for management.
Right, okay,
but 60 to 100 is normally the reference range.
So when in atrial fibrillation, the top two chambers can be beaten at about, it can be even higher than that, could be like 200 to 300 beats a minute, but the signal, the electrical signals can actually downplay that, so then when it actually goes to your ventricles, it's about 140, because obviously anything above that, you would die instantly. I did read that was actually like true.
But like we said, one of the nodes is a gatekeeper, and it's got a refractory period, which means during that period it can't be excited again, so you cannot cause a contraction.
Why it's really clever.
And carrying on throughout this podcast, I'm going to call it AF, not atrial fibrillation.
Yeah, it's a bit of a mouthful.
It's a mouthful going forward.
Yeah, so in terms of AF and atrial flutter, like we said, they are very similar but different in like the physiology. However, the treatment for both of them is the same.
Yeah. And the symptoms will be similar. Yeah. You've mentioned some of them at the beginning.
Yeah, I did.
Which is shortness of breath, tiredness, chest pain, palpitations, dizziness or feeling faint. But a problem is that at least a third of these patients don't show any symptoms whatsoever, so they're asymptomatic. So when it comes to a patient having a newly diagnosed stroke, a lot of the time they find out that they've got AF. Yeah. It was just that it was never detected in the first place. Yeah,
because I think if you've got AF, it increases your risk of stroke 5 times more than like a person in the general population. And about 10% of ischemic strokes, so strokes that reduce the blood supply to your brain, are related to AF. And they're the ones that are detected. The 10% is the ones that are detected
for the first time.
Yeah. You know what I mean?
Yeah. So I mean, it might be good to go on to causes and risk factors.
Yeah.
So there are things that are modifiable, things that we can change, but then there's non-modifiable. So, well, I mean, this is open to discussion, but gender.
Yeah.
So males tend to have a higher risk.
Yeah.
And then in terms of age, it's not something that you can modify, but it is a disease or condition that increases with age.
Yeah.
So if under the age of 55, there is a 0.2% population who will have it, whereas over 85, it's a 10%.
Yeah. I think also just to point out with that one is that in the media, I think it was the last year, I think it was, where AF has been detected in younger and younger people. So like people in the 20s and 30s. So I think I read that it could potentially be to do with binge drinking, because I don't know whether you mentioned it yet, but alcohol is a big risk factor for developing AF. That's one of them. Obviously, use of illicit drugs could be another.
Yeah, so cocaine's got the biggest impact.
Yeah.
There are some studies on that already, but not big enough trials to conclusively say.
Okay. Yeah, and then the other one I read was pericarditis. So this one is a bit of a weird, not a weird, but a bit of a taboo subject. But obviously, when everyone was getting the COVID vaccines, that was linked to increased risk of developing pericarditis, which is inflammation around the heart. So there was a discussion whether it could have been to do with that. So like as a side effect of the COVID vaccine causing the pericarditis, then increasing the risk of AF. However, I didn't find any papers or anything on that. So that was just kind of something that I read in the media. So, you know, you have to take that with a pinch of salt.
I think we'll have to do one on COVID vaccines.
Yeah.
And cover everything.
Yeah.
But I mean, other things that we have in today's society is caffeine. So increased caffeine, again, the way it works, increases your heart rate. Anything that increases your heart rate does increase the risk of having arrhythmias, which is the irregular contraction of the heart, which AF is classed as. We've got illicit drugs, you've already said. If you've had any heart surgery, stress in general. Yeah. Diabetes is being classed as one now. High blood pressure, because of the way it affects your heart. And then we've got smoking. Acute infection's quite a big one. So when we do discharges, a lot of the times that people develop it for the first time are after an infection. And that's mainly because your heart rate increases. There are all other factors that act in response to an infection. Yeah. That's the main thing that we look out for. The causes are actually still unknown.
I was going to say, yes. Fully. I read that the causes potentially could be to do with something called cardiac remodeling, which is when your heart muscle tries to kind of regenerate itself after it's been damaged. So if you do have things like hypertension, you are putting a lot of stress on your heart, and so inevitably it will become a bit damaged. So then your body's kind of natural response to that is to try and fix it, and so it'll like bring a whole host of like different white blood cells and things to the tissue in question, and like kind of trying to help itself. It damages itself and then causes cardiac remodeling, which then can increase your risk of developing AF because it can affect the electrical signals passing through the heart. So I did read that as one of the potential reasons.
Okay. And there's a lot of medication once we have these conditions that do affect cardiac remodeling, such as beta blockers, and then we've got angiotensin converting inhibitors. Yeah,
so things like ramipril or candesartan, anything with sartan or ill tends
most
to
of the
be,
time,
most of the time, one of them medications.
But going on to the stats you said before, the biggest thing that comes from AF is not about the speed of the heart rate. We can monitor and manage that in community by using different techniques.
Yeah.
The main thing is the stroke risk.
Yeah.
So when someone's diagnosed with AF, well, actually there's a couple of types of AF, isn't there, as well?
Yes, there is.
So we have AF, which is permanently there.
Yeah.
And then there's one called paroxysmal AF,
Yeah.
which basically means that it comes on and off.
Yeah.
And the chance of detecting these are quite low. So I did look at something before with the use of smartwatches.
I did read that myself, actually.
Have you just seen that?
Yeah.
Yeah, so when a smartwatch detects an irregular pulse, 84% of this was caused by AF.
Yeah.
But when you do an ECG, for example, you go to the GP surgery, say, oh, I've got palpitations. If you get an ECG, that's only taking a snapshot of what's happening at that point.
Yeah.
So if you've got this PAF, I'm going to call it,
Yeah.
it won't be shown. So that's why you need to do a 24-hour ECG, which is the one that you'll get from the hospital normally.
Yeah.
And it'll give you a greater...
A better, yeah. But I did read as well, though, even the 24-hour ones may not detect it, because it could be for longer periods that you don't go into AF. So I think that brings us on to as well kind of monitoring or like identification of AF. There was studies that were looking at rolling out a screening of the whole population. So at the moment we do breast screening or we do bowel screening for high risk patients. So they were looking into whether it was beneficial to do it for AF patients. So I think...
Oh, you mean like opportunistic?
Yeah.
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 Because we are getting better at that for diabetes, for example. If someone who comes in who's obese, we'll do a blood test, the HbA1c, and go, oh.
Exactly.
But we don't routinely go, well, you sit down there and I'm going to strap a few electrodes and we'll do an ECG.
So like we said at the beginning, obviously if a patient is over the age of 85, they're at an increased risk of AF. So would it be beneficial to say, okay, well, we've got this patient in now in the surgery, we may as well do an ECG just to double check. But I think...
Well, there was one actually with a lot of sexual health.
Yeah,
so a lot of STIs, so chlamydia, for example, they were taking them as an opportunistic.
But yeah, so that's like one thing, because I think I know that nowadays pharmacists obviously do the enhanced services, so they are supposed to do like a pulse check, and what happens is if they do detect an irregular pulse, then they have to wait 5 minutes, check it again, and then refer to a GP.
So is this relating to the blood pressure machines? Because this is the thing. So AF has an irregular pulse. So it's irregular in terms of it doesn't look as normal, but then that irregularness doesn't occur on a regular basis, so it's a weird one. But yeah, if you do an automatic blood pressure, the machine will come up with error.
Yeah.
So then you're advised to repeat it again after 5 minutes, but that's why you've got to do the manual blood pressures when you do have AF. Now, going on to once you've been diagnosed, the management. Yeah. So the biggest thing is to avoid stroke. Yeah. So how do we avoid stroke?
Yeah. So the biggest thing for avoiding stroke is to commence a patient on an anticoagulant. Examples of these are DOACs, which are the newer ones that we use now, and we tend to use them more often now because there's better studies in them, isn't it? Well, they're actually better than warfarin, which was the old one.
And what are examples of DOACs for people who don't know that term?
Examples of DOACs are adoxaban, rivaroxaban, apixaban and dabigatran. So they're the 4 DOACs. Adoxaban is what we tend to use first line in the UK. I think it was something to do
But this is controversial,
It is, yeah.
Because there are no direct, large head-to-head studies. Actually, apixaban is the best studied. Yeah. And in terms of side effect profile, it's better responded to. Yeah. But yeah, adoxaban was... The manufacturers were aiming to bring out an app, increase the awareness of AF, and bring out other financial incentives. So it wasn't for the clinical benefit of the patient. And that's why I didn't really change them.
Yeah, no.
On what grounds would you be legally covered?
I know. It was a difficult one. I think guidance said anyway, it had to be like a patient by patient, like a decision made on, an individual case rather than just switching everybody over to...
Well, that's why I found it hard, because when they were saying, what's the point in me coming over to this? It's like, well, there's actually no studies to say the one you were previous on was probably better. Yeah. So I didn't change them. Yeah.
The only thing, one of the good things about it is that it's a once a day medication, so compliance may be better. However, there is like a bit controversial, because with it being once a day, if a dose is missed, then it could potentially be out of the body quicker than if it was a twice a day, due to half-life and things like that. So if you do miss a dose of your once a day medication, you could then be increasing your risk of having a stroke, because you've got no drug in your body, if that makes sense.
Yeah, I mean, we're not going to go into these DOACs and anticoagulants in too much detail here, but you've just brought us on to why we use them now, because they have a shorter half-life, which means they spend less time in your body if you do miss a dose. But they're more predictable. So when you had warfarin, you have to go weekly to 2 weekly at the beginning, and then it's every 12 weeks on average, isn't it?
Yeah.
To get your bloods checked, whereas these are normally 6 monthly if you're over 75 or a poor kidney function, or yearly if you fall out of these categories.
Yeah.
It can be increased depending on, but
yeah,
that's the general rule of thumb.
Yeah. The only thing that we have to keep an eye on really with these is a patient's kidney function. So as patients tend to get older, your kidney function just naturally does decline anyway. So we need to make sure that we're monitoring that, because the dosing of these medication is based on that. Weight of patients as well, so we have to weigh patients in order again to dose them, but patients with extremes of body weight haven't really been studied, so we don't fully know how well the drug works in patients who've got a really low body weight or a really high body weight. So in them patients you may want to consider something like warfarin, where you can monitor the how thin or how long it's taken for the blood to clot, just to get just basically for safety reasons really, isn't it?
Yeah, and like you said, weight is one of the biggest things that are missed during annual monitoring. So we'll get the bloods done, that's fine, but then there'll be a weight from 2 years ago. We actively need a weight to work out your accurate kidney function, and in some of them, the Adoxaban, it's based on weight anyway.
Yeah.
The dosing. I was just going to say, we went off topic, so we're going to come all the way back to...
Because I was going to say, we kind of then just touched on who can't have it or who can have these medications. So with the DOACs, like we said, so if you've got a poor renal function, usually below 15 mils a minute, that might not mean anything to anybody, but
renal function being kidney function.
Yeah, kidney function. Then they are contraindicated, which means that you definitely can't have them. So in them patients, we do need to think about warfarin. They're also not licensed in patients with valvular AF. So that's AF that is associated with something like mitral stenosis or aortic stenosis, or in patients that have got a mechanical valve replacement. So that's something to bear in mind as well. Any patients who fall into that category will also need to be on warfarin.
And that's because they're not studied in that. And during COVID, when people couldn't get the warfarin monitoring, they went across to these DOACs, and then I think there was 14 events.
There was, yeah.
Don't know whether there was 2 deaths.
Yeah.
But we had to change everyone back who'd been wrongly put on that, because, like you said, there's no licensing for that.
Yeah.
But with AF, there is a calculator called the CHADS-VASc score, which in the first place sees whether you are in need of an anticoagulant.
Yeah. So that's important to note, that not everybody needs to be on anticoagulation if they've got AF. The majority of patients will, however, not everyone. So Lee will explain now what criteria you have to meet in order to be considered for anticoagulation.
Yeah, so females, this is what we were discussing before actually. So males have a higher risk of developing AF. We haven't actually mentioned this today, but females have a higher risk of mortality and complications.
Yeah.
So when you look at the criteria, you do this CHADS-VASc score, which incorporates a few of the following. So your age, if you've got a blood pressure, you've got heart failure, diabetes, previous stroke. If you're female, you score 1 point, and if you've got any vascular disease. Yeah. So then when it comes to interpreting the scores, a male of a score of 1 or 0, you don't give any.
No. Anyone who's got a score of 0 would not be anticoagulated.
But females by default have a score of 1, and they're not considered.
Yeah.
But then it goes to, once a male has a score of 1, then they're considered, and if a female or anyone who has 1 of 2, everyone's considered then. Yeah. And why we do this is they've done studies in terms of treated and untreated with anticoagulants and what the stroke outcome would be. So if you've got a CHADS-VASc score of 2, there would be 25 strokes per 1,000 people a year if no one was treated. Now, anticoagulants prevent 17 of these, and then 8 of them will still carry on, even if they are treated to have a stroke. Yeah. And the benefits of being on an anticoagulant completely outweigh the risk of a minor bleed, because a bleed risk doesn't interpret or doesn't scale the actual event, the size of the bleed. Yeah. So anybody who does have AF, their GP practice should be checking the CHADS-VASc and their bleeding risk, which is usually the orbit score now, every year, just to reassess that the patient's definitely on the correct treatment. Like we discussed before, there's very few reasons where you would go off the orbit or has bled to stop or not give anticoagulation. It's just normally to see what is modifiable to reduce your risk going forward for bleeding. Because I think I just wanted to mention this, because I had a patient last week who had suffered a bleed on a brain,
early last year, I think it was. So she was on anticoagulation because she'd been diagnosed with atrial fibrillation, and her CHA2DS2-VASc was, I don't know what the actual number was, but it was deemed that a risk was high enough to start it. Subsequently, she then developed this bleed on her brain. She was fine and it was treated in hospital, but as a consequence, they stopped her anticoagulation at that time. However, then she was seen by the neurologist a few months later as just a follow-up, like a routine appointment, and they said that it potentially would be wise to reconsider starting anticoagulation. Because I think, actually, no, I do know a CHA2DS2-VASc was something like 6, which is very high. So I think, have you got the stats of what the stroke risk would be with a CHA2DS2-VASc of 6?
I've only got it going up to 5.
Yeah.
So up to 5, there would be 84 strokes.
Yeah, so it
untreated.
It was high. And it was deemed at that point then, because she'd overcome the bleed on her brain, that it would be what, yeah. So anyway, that was restarted, but that's just kind of something to point out, that even if a bleed on the brain would be not something to even, obviously you would stop it at the time, but then you would need to reconsider.
Yeah.
Patient by patient basis, obviously, and with a consultant.
And another thing is falls risk. So a lot of patients used to be like, oh, well, if I fall over, I could bruise and bleed internally, etc. They did do a study where they reviewed warfarin in patients, and a patient had to fall 295 times to outweigh the benefits of being on warfarin.
That's crazy, isn't it?
Which is, I mean, when we first started doing pharmacy, it was drilled into us like a few falls a year was catastrophic. So to hear that number, it's reassuring, isn't it, really?
It is, yeah. You can also do something called left atrial appendage occlusion. So your left atrial appendage is basically like where blood can pool. And again, like we said at the beginning, if blood can lay stagnant somewhere for a prolonged period of time, then it does tend to clot. Obviously, if this then leaves your atria, again, travels to your ventricles, it can then go to your brain and cause the stroke. So they do it via like a catheter. So usually in your groin or in your arm, and they basically just block it off with like a mesh, and then it just means that blood just isn't able to clot there anymore. So it's usually for patients who have contraindications to being on an anticoagulant. So it's usually elderly patients, and then also patients who have been on other treatments and they've failed. The other thing is that usually when they do it, it's for patients who are already going in for another procedure, so like a cabbage or something, and they'll just do it like opportunistically at that point.
What's a cabbage? It's not something you need.
Oh yeah, sorry. So that's...
No, I always make the mistake of including all these terms and forget that some of the audience might not know what it is. So
a cabbage is a coronary artery bypass graft, and it just means that your heart's got blood vessels that supply it with oxygen, and sometimes these can become blocked with things like plaques that have built up over years. So they just use a graft basically to bypass it. I'm trying to think of like a way to describe it.
They just divert.
Yeah, it's like diverting
it's just
traffic, really.
Yeah, that's all it is, but it's a fresh new artery.
Yeah.
It's not covered in plaque. So that's why it does work. It basically feel completely resolved after it.
Yeah, so usually if you've got a patient who is going in for a cabbage and they've got AF, the cardiologist will sometimes think, oh, okay, we'll perform the left atrial appendage occlusion.
So we've discussed anticoagulation within AF.
Mm-hmm.
There are more details to go into, which we will touch upon in future podcasts. But in general, you do a score to assess what your risk of having a stroke is. You have a look at your bleeding risk. Yeah. And then you tailor whatever anticoagulant fits you, whether you need warfarin due to your weight differences or whether you want a doc because compliance and adherence to medication is a big thing, then you can start them on that.
I was going to say as well, just like as a side note, the Big Tran can't be put into blister packs or pill pouches. So that's just something to consider. They have to be kept in their original packaging. So if you've got a patient who is on a blister pack who needs that for the adherence, that's probably not going to be the best one for them.
Yeah, and same with warfarin as well, because the dose does change.
Yeah.
But the next thing to do with AF is controlling the rate. Well, controlling the heart, because it then depends on whether it was new onset or what the cause was, how we treat it. So there is rate control and rhythm control.
Yeah, so like we said at the beginning, you've got this fast heart rate, your heart's beating out your chest, you've reduced your stroke risk by giving an anticoagulant, so what are you going to do for all the other symptoms of breathlessness and dizziness? That's where these drugs come in.
Yeah, and a lot of the time it is secondary care, so hospital, in a clinic that decide this. The GP will very rarely They may start you on anticoagulation before.
Yeah, so you're supposed to start anticoagulation before. It doesn't actually specify a time frame from diagnosis of AF to when you start it, but obviously every day that you're not taking anticoagulation, your stroke risk is increased. So they say as soon as you can start it. Important as well to note that you don't need to check bloods for AF. However, it's beneficial to check your bloods because you'll need that for dosing of an anticoagulant anyway. So think full blood count, liver function tests, kidney function tests.
Do your thyroid as well.
Your thyroid,
that is a potential cause.
That is a potential cause, and then also your weight, which we mentioned is one that always gets missed.
Always.
And then you could even do your clotting potentially, just so that you know that there's no underlying blood disorders going on that may, influence your ability to start a patient on an anticoagulant.
Yeah. But in terms of treatment, rate control is the most common one, where you're given something like a beta blocker, which literally controls the rate.
Yeah. Sometimes a GP can also start a beta blocker. That's the only one really that a GP would start in primary care. But
most commonly bisoprolol, isn't it?
Yeah, and in my own experience, I feel like they will start anticoagulation, but they will just generally refer to a cardiologist about, sometimes they will start bisoprolol, but some doctors will just refer straight away.
Because the symptoms are so non-specific. Yeah. You need to check the structurality of the heart, etc. But rate control is a common one, and then we just adjust it to. So like I said, I only found out before less than 110 beats per minute. Yeah. Whereas in reality, we probably aim towards a 70, 80.
Yeah.
The reason why they were so relaxed on it was that they found out keeping it under 80 beats per minute had no benefit.
Yeah, and I was going to say anything below 50 is too low anyway. So if they do go below that,
in a medically treated patient. Yeah. If you're Lance Armstrong or someone else, you might be 35 beats per minute, but your heart is capable of doing that because it's strong enough. Yeah. Whereas if you're medically inducing that, it's
that's
weak.
when it becomes dangerous.
Yeah. Well, yeah. And then other forms of treatment. So you've got the cardio version, which is more towards the rhythm control now.
Yeah, and that's definitely specialist.
And that's normally within, I think it's 48 hours of the symptoms.
Yeah, although I had a patient today, which I was going to discuss as well, who is newly diagnosed with AF. He was started on bisoprolol for his rate control. Heart rate was about 60. So I don't know what it was previous to that, but it was within the range, probably a bit low on the lower side, but it's fine for clinically being okay. He then developed diarrhea and constipation, so was re-referred to the cardiologist. They said, okay, we'll stop your bisoprolol, we'll switch it to diltiazem and flecainide, which are another two rate control medications. And then when he started them, he felt even worse, so he since stopped it. And I had a phone consultation with him today actually, because he's waiting for cardioversion. So that was what I was going to touch on, is that he said it could be 18 months before he gets it, so wait times at the moment for it are very long. But anyway, he stopped it, and he said he was drinking a lot of alcohol prior to being diagnosed with AF, which he's stopped now. So he said, I haven't actually had any symptoms since, I've stopped all the bisoprolol, diltiazem and flecainide. And he said the cardiologist did say to me that I didn't have to be on any rate control. So that's what I was going to ask you, because I passed it on to the GP to just make sure today. But I wasn't sure whether, if you have AF, do you have to be on a rate control medication?
Not if your heart rate's within the limits, no, because I think the main concern is making sure your blood is passing through and it's not pooling. Yeah,
that's what I did think. I just wanted to double check, but yeah, that was just...
Because like you said, if someone's naturally got a low heart rate, you're not going to induce it to go further.
Yeah.
So cardioversion as well, the other risk is that because the blood's not being effectively transported, if you correct that by giving an electrical shock, there could be a clot within the heart. So normally you've got to weigh up anticoagulation at the procedure as well. Oh, yeah, so even in them 2 days or however long it's manifested over, there could be something there. So if you've just started up again and it's working, that can go off.
Yeah, that's true actually.
There is also ablation. Yeah. That is common. Now, that's just basically where you burn or freeze the parts of the tissue within the atria that are causing these spontaneous impulses, other than the actual node. That actually is another form of treatment, but that's a bit more complex. Yeah. So now that we've went through all the treatments, or the majority of them, there are a few people that you will look at in the GP surgery that will be coded as resolved AF.
Yeah.
So this one used to throw me off until I could find the guidance on it. But what do you do with these patients?
I don't know, actually.
Yeah, so in terms of they've been coded as resolved, normally I think it's more of a mistake because these patients are more commonly diagnosed with PAF. But at that point, they had an ECG, they have not picked it up.
Yeah, yeah.
But then at this point, even though they're resolved, they are still 1.4 times higher risk of stroke.
Okay.
And they shouldn't really stop anticoagulation. So that was the point that I was trying to see, because I had a few patients where they said, well, I've had an ECG, it looks fine, what do I do with this blood thinner? And I was like, well, actually, I don't know. So we had to go and have a look.
So I actually, now you've said that, it's brought back like memories. But I had a patient recently who was newly diagnosed with AF following an infection. So they'd been in hospital, I think it was with like community acquired pneumonia. Subsequently developed AF, was started on treatment, and then they were referred to the cardiologist, which is usual protocol for those types of patients. And then had a 24-hour ECG, and they were no longer in AF. So at that point it was stopped, and I remember kind of seeing it on obviously the letter that came through, and I just passed it by the GP and I was like, are you happy for this anticoagulation to stop? And because it was an acute episode of an infection that was the known cause of it, they were happy for it to be stopped. But I wonder...
I mean, that study that you mentioned before, where they're trying to increase the length of monitoring, there was one where they'd done over 30 days.
Yeah.
And they'd done it against someone who was monitored for 24 hours. And the 24-hour monitor group, 11% of them had anticoagulation started because they found it, whereas in the 30-day it was 19%. And they were significantly different, enough to make a comment on it. Okay. So that was a far off double, just by increasing the monitoring period. Yeah. So in these patients, they may look good for that little snapshot, but like with any form of treatment, it is an agreement between the patient and the prescriber. Yeah. So if the patient could have the worst blood pressure in the world, for example, but if they don't want to go on treatment for whatever reason or belief, they've got to accept that. And that's the hard thing about medicine, I think, is that a lot of decisions will come back to you, even though you've had this discussion with the patient. Yeah. And they'll say, how come this patient's not on this? And you'll say, well, we've had this discussion, they didn't want to go on it. Yeah. Yeah, like all treatments, it is an agreement between the two of them. We discussed at the beginning about modifiable risk factors. Yeah. Do you want to touch upon lifestyle factors that you can change?
Yeah, I mean, risk factors for AF, we discussed them, the first one being obesity. So a 10% reduction in weight can reduce the AF burden. I don't know by how much, it doesn't, I haven't read that,
I'm not too sure.
Obviously, I mean, a 10% reduction in weight anyway has a lot of, if you are overweight or obese, has got many benefits, which we will touch on in other podcasts, but in this particular one, it reduces your AF burden. Physical activity, so actually I didn't touch on this before, but marathon runners tend to have a higher increased risk of AF. However, if you do regular aerobic exercise, that can reduce your AF burden.
Is that just due to the stress?
It must be. I just read it. I didn't go into any detail of it. It just said that it potentially could be. Whether it's a correlation or a causation, I don't. You'd have to look at studies into it. But
that's the biggest, and that's something that we're going to go on about risk later on. But correlation and causation. Do you want to explain it?
No, go on, you can. Oh. You're better.
Okay, so it's like saying everyone who lives in Liverpool is good at footy, when in reality it could just be that is just by chance. Yeah. It's not living in Liverpool caused you to be a good footy player. Yeah. It's just that by chance everyone that lives there at the moment is good at football. Yeah. And that's the same in medicine. So if you've not went out to directly study something, you can't say it's a finding.
Because it just popped into my head that marathon runners will tend to have watches. So they'll tend to have watches that may indicate that they've got an irregular heartbeat. So then it just might be that they're getting picked up more often because they're wearing devices that can pick up that they've got an irregular heartbeat. Do you know what I mean?
And also the amount of stress that they're putting the body under
so it could be, but immense. Anyway, that was just something that I thought to touch on. Alcohol obviously is another one. So if you drink more than 10 units a week, so at the moment in the UK, current guidance is to drink no more than 14 units a week, both men and women. So if you drink more than 10, then you are increasing your risk of developing AF. So that's something to look at. If you are abstinent from alcohol, it will reduce your episodes of AF, whereas excessive alcohol intake triggers it. Smoking, so there isn't any specific data for that, but obviously smoking cessation is something that we will always advocate for. You know, we obviously know the risks of lung cancer and other types of cancer with smoking, so that's, you know, something to say. Sleep apnea was another one that can increase your risk of AF. So patients who are on CPAP, which is a device that they wear at night time to to reduce the risk of episodes during sleep where they stop breathing, reduces the risk of AF. Good control of hypertension also reduces the AF burden, and then also good glycemic control in diabetes patients will help with AF burden too.
Yeah. One thing we didn't touch upon on management was we discussed anticoagulation and those resolved or with PAF, but we didn't say what normally happens with the rate control or anything, such as pill in the pocket.
Oh yeah. So actually, that guy that I did speak about before, he potentially might have been a really good candidate for pill in the pocket. So the pill in the pocket is usually when a patient does have PAF, which is the AF that comes and goes. So he's on his anticoagulation, he's not getting any symptoms of his AF. However, every now and again he might feel like some palpitations, so he would be a good candidate for that, because then he takes a pill called flecainide or something similar, and it will resolve the symptoms at that point, but he doesn't have to be on it every single day.
Yeah, that's the best thing. I mean, that's decision again, that's made within the clinic and hospital or tertiary care, but yeah, it's a good option, isn't it?
Yeah.
I mean, one of the take-home things from this is that this condition is increasing in prevalence.
Yeah.
Whether we're getting better diagnosing or whether it is a general increase for health reasons, I'm not too sure.
Yeah.
But they reckon, so this is from the British Heart Foundation, that 270,000 people within the UK are undiagnosed.
Wow.
Which then does translate to a lot of patients getting stroke without many causes.
Yeah.
So when people get a mini stroke, which is basically, you've got the symptoms of stroke such as face droop, slurred speech, whatever, and then you can't actually find a cause when you do a CT scan or any monitoring. So that's called a mini stroke.
Yeah.
And a lot of these could be due to PAF.
Okay.
That's what they're finding out.
Yeah, so probably, even though it's difficult to diagnose, if you do have any of those symptoms that we mentioned, so, you know, palpitations of your chest, like feeling weird, your heart's like racing, breathlessness, dizziness, even fainting potentially, like you can, you know, lose loss of consciousness. Obviously, I would always suggest going to the GP anyway or to the hospital, but if you have any of them symptoms, also if you have any risk factors that we've mentioned, and along with those symptoms, it's probably worth just going to the GP just to get checked out. Yeah,
and like you said at the beginning, we were discussing one possible cause, but palpitations, etc. There could be anxiety, infection, shortness of breath, could be asthma. Yeah. There are so many conditions that are related to these things, but there is one thing that's happened since all the football players have been dropping with cardiac problems on the pitch. My brother ended up going for the scan, didn't he? So it was a cardiac monitoring of the young. What was it called? The campaign, the charity.
The charity is called CRY, so it's cardiac risk in the young.
Yeah, so they do an ECG, and again, like we've said, it may not pick up anything. Yeah. And an ECG is not just there for a regular heart rate. It can see if there's anything being blocked. It can also, see if there's any abnormalities within the heart. It gives you a good overview, but that's a free thing, and it's a good charity that I think the closest one to here was Salford. Yeah. So that's where we went to, but yeah, that's a free service, and again, that's just showing that there's a lot of undiagnosed heart conditions out there in seemingly healthy people. Yeah, there was one more thing that I personally wanted to touch on, just like quickly, because I think we will touch on it more when we do the anticoagulation podcast, but with anticoagulants, they do increase your risk of bleeding, just the nature of the medication. So in any patients who's over the age of 65, who started on anticoagulation, we will assess for the need for a proton pump inhibitor, a PPI, something like a omeprazole or lansoprazole, and that is to reduce the risk of gastrointestinal bleed. So that was probably just something to touch on if you are someone who's listened to this podcast who's taken any of these medications and is over the age of 65, not currently on a PPI. It might be worth just speaking to your GP about that or your pharmacist. And coming on to bleeds, I mean, this might be more applicable to healthcare professionals, but there are times when a patient can be on an anticoagulant for AF and also an antiplatelet due to a previous heart attack, peripheral vascular disease. And a lot of the time we just stop the antiplatelet because, let's say you've got a patient who's had a heart attack 5 years ago, they're stable since then, they've developed AF, they would then just be managed on an anticoagulant. But in some patients, if you had a heart attack last year, now new AF this year, they will probably be on both of them.
Yeah.
They are at an increased risk of bleeding.
Yeah.
Monitoring them, probably be put on a PPI, like you just said, the omeprazole, lansoprazole, depending on what interactions are there. Again, this is a decision that's made at a clinic level. It's not the GP or the pharmacist at the surgery that will make this.
Yeah, I think also, just looking then, there was a study on patients who were on warfarin for AF plus an antiplatelet for another condition, and they were actually at no greater GI bleeding risk than those on just warfarin alone. That was obviously just one study, but like you say, that would be a decision made by a cardiologist. It wouldn't usually be started in primary care in a GP surgery.
Yeah. So this was a new type of podcast that we've run out. So we've not told each other the questions beforehand, what we've had. We've let it run off on a discussion to see where we end up. I think it went well.
Yeah, I think it's gone probably better.
It did go off because there's a lot of topics to discuss with regard to atrial fibrillation. But take-home messages or an overall summary, do you want to provide one?
Yeah, so I would just say, first of all, the symptoms of AF is like what we discussed. If you have fast heart rate, or you feel like your heart's beating out your chest, if you've become short of breath, if you feel dizzy, they could all be symptoms of atrial fibrillation. There are modifiable risk factors such as being overweight, having poor diabetes control, poor control of your hypertension, alcohol intake, which can increase your risk. So we would always advocate to kind of modify those risks regardless of, of AF or what. But yeah, those could mitigate your risk. If you are diagnosed with AF, usually you will be seen by your GP. They will refer you for a 24-hour ECG usually, and before that they will usually assess your risk of whether you need to start an anticoagulant or not. Then usually you will be referred to a cardiologist who will do your 24-hour ECG and then assess you whether you need rate or rhythm control, or whether you need something like we discussed, ablation or cardioversion. You must be getting monitored for your bloods every 6 months in some patients, and at least every year. And in that, a pharmacist or a GP or a nurse should be assessing your stroke and your bleeding risk, as well as doing your kidney function bloods and everything, so that you're being monitored to see if you're on the correct medication for it. If you ever did develop any bleeding while you're taking any of these medications, if it was bleeding that didn't stop, and it was obviously heavy bleeding, then you need to go to your local A&E department. If you ever experience any severe headaches, any bruising that was like severe, any blood in your stool, any blood in your urine, again, you need to see a medical professional, because it may be that you're on maybe too high of a dose of your anticoagulant, or they need to maybe switch it to something else. And I think, is there anything else that you would like to add into that?
No, I think that was a good overview. But like always, this is for informational purposes only and not to be used in substitute of seeing a healthcare professional. Yeah. I'll start by saying thanks for listening this week.
Yeah, so thanks for listening, and if you have any other topics that you'd like us to discuss, or any questions relating to this podcast or any podcast that we've done previously, then please drop us a message. But yeah, thanks for listening.